if that's something mistake and did not speak in Chinese, and please forgive me. So this is a disease of the protein misfolding and subsequently deposit as amyloid fibro in the many organ. Actually, go back here. So this is a little video here showing the protein once it's misfolded and will folded, plated the beta sheets and eventually deposit as an unsoluble amyloid fibrils in the organs. So. And when they're talking about amyloidosis, I think mostly commonly everybody know it's Alzheimer's disease, Parkinson's, Huntington. It's all related to a brain disorder. But unfortunately, brain do not have this exclusive right for amyloidosis, and heart also has it. So when it's come to heart, there's generally few a category of cardiac amyloidosis. And most notably, it's aortic amyloid cardiomyopathy, and that's a common systemic amyloidosis in the U.S. And the other type is from transthyretin protein, and then come in two flavor. If it's a mutation related and it's familial amyloid cardiomyopathy, or it's wild-type TTRs, and there will be a senile amyloid cardiomyopathy. And then this, and generally, is a late onset, and particularly senile amyloidosis generally happen in the third quarter and after of the life. So today I want to focus on my presentations on AL, or it's called primary amyloidosis. So as you can see here, the AL primary amyloidosis is actually from the immunoglobulin light chain actually producing the B cell, so it's a chronoplasma cell. So you produce this and circulating in our system. And they come into two flavor. So some of the immunoglobulin light chain would not form as amyloid deposition, will be just a protein circulating, and that's actually a cancer, multiple myeloma. And the other type, those protein will actually undergo misfold and deposit in the various organ in our body. As shown here, this is actually pretty much affect all organ in our body, showing here heart, kidney, liver, soft tissue, lungs, and anything you name it, and intestine as well. But mostly commonly actually affect heart and the kidney, and was mostly it's in the heart. When they come to cardiac involvement, actually very detrimental. As you can see here, this is actually the old data, and this is when the time we start investigate this disease. As you can see that, with a cardiac involvement showing us a higher cardiac troponin T circulating level, its median survival rate only 4 months. So this is actually worse than any cancer or any cardiomyopathy, as you can see. So back then, the hypothesis or the theory of the mechanism underlying this disease is actually the infiltrative one. So namely, as you can see here, is a healthy heart, and this is a cardiac amyloid heart. You can see a thicken of the ventricular wall. Don't make a mistake as compared to hypertrophic cardiomyopathy. This is actually the category as a restrictive cardiomyopathy. As you can see, a much reduced ventricular volume and thickening of ventricular wall. You see this shining, waxy looking, actually it's not cardiac muscle cell, it's actually amyloid protein fiber deposition. You can see here also in the echocardiography showing the thickening of the ventricular wall, but that's because of full of truckload amyloid fiber deposition. So in the past, the theory is this infiltrate of amyloid fiber affect the stiffness of the heart, and therefore increasing impair their contractile function as well as diastolic function, and most notably, it's represent as a diastolic dysfunction and ultimately developed heart failure. But however, a clinical observation actually suggests there probably is more to this disease mechanism than the amyloid fiber deposition. Showing here actually is a survival rate of two types of cardiac amyloidosis as shown earlier. One is by the precursor protein ATTR, and the other is from immunoglobulin light chain. These two types of cardiac amyloidosis, if you based on the echocardiography measurements, their amyloid fiber load actually very similar. So if the old theory, the passive restriction of the amyloid fiber to the cardiac contractile and relaxation function, then these two groups of patients, their mortality would have been the same. As you can see clearly, aortic cardiomyopathy patient has much worse the survival rate compared to ATTR. So this actually trigger, we come to the hypothesis as this immunoglobulin light chain protein may intrinsic possess some sort of a cellular toxicity and lead to the early mortality. And over the years, my laboratory with many fellow, actually this is not the war, this is actually a fellow actually got his MD and PhD from China and working in my laboratory to get his second PhD. This is not the war, this is James Gong. So this is a cardiac, we over time and map out really the disease mechanism, you trigger all these cellular events and eventually lead to cell death. But however, here we still cannot demonstrate the increasing mortality as you see in the AL patient is indeed triggered by this proteotoxicity of amyloidogenic light chain protein. So this is actually what we see in the patient. That's a much drastic of this mortality. This is back in 2 decades ago, and this is really very detrimental. And so we try to address whether this proteotoxicity is sufficient to drive the mortality. In order to do so, my fellow Shikha Mishrat take on this project and try to establish the proteotoxicity model using Zebrafish. So what she did is she injected amyloidogenic light chain proteins in the zebrafish 40 hours embryo. At such stages, zebrafish heart is fully developed, so we not confront with the developmental issue. So when the heart at this stage, she injected, micro-injected into the fish circulation of amyloidogenic light chain protein, as well using myeloma patient light chain protein, which is non-amyloidogenic, as a control. So the control group also received light chain injection, just different type of light chain. And then this is something we're really excited to share this, because this is probably one that's more really clear cut to looking at the mortality, because you don't have anything you need to count. We put the fish into the 6 well plates, and every morning she just count how many fish it died. So this is a result show. It's very striking. The fish received the AL light chain injection displays actually much profound mortality as we see in the patient, versus compared to vehicle injection, that's the media, as well as the control light chain, is the light chain from the myeloma, non-amyloidogenic. So this really supports really that this toxic, proteotoxic effects not only affect the cell death, they also affect the mortality. And this is very similar to what we see in the human. And so anything has a toxicity. If that's a regular toxicity, we would expect that maybe have a dose-dependent effect indeed. When Shikha inject a different kind of a concentration of this immunoglobulin light chain, a protein in the fish, you can see a dose-dependent. By affecting the concentration by 10-fold less or 10-fold higher, you completely alter the mortality rates. And we are very gratified to seeing this actually supported by the clinical observation. For those AL patients receive a chemotherapy to remove their circulating light chains, you can see if you remove the circulating light chain greater than 50%, it's already altered the patient's survival rate. Versus those non-responder, that the patient's mortality is really poor. So you can see this, really we can using this method going forward and ongoing, we are using this, try to determine which light chain protein is more toxic, and to help hoping to using this to guide the clinical therapy. So over the years, my laboratory has mapped out the signal mechanism, regulate this AL immunoglobulin light chain induced cardiotoxicity. At the proteotoxicity arm, we see this immunoglobulin light chain immediately quickly activate stress kinase, and then subsequently downstream of signal cascades and cellular events ultimately lead to the cell death and also the fish animal dies too. And on the fibro arm, fibro also causes the dysfunction, but however, it's mostly focused on the structural damage. It increasing the cardiac and the vascular stiffness, and the impaired contraction and relaxation, most notably is in the relaxation arm and disrupt the electrical conductance as well. And so when we're doing the basic research, that's always our goal, hoping what we find in the molecular label, whatever the target we can identify, we can bring this and translate from the bench side back to the backside. Can we do this? This is just using the proof of concept. This is a simplified cascade of the signaling mechanism we map out. The extra size is showing we target in this P38 MET kinase, also STC1, over mitochondrial function. We asking question, whether by target this signaling cascade, we able to alter the survival of the fish. As you can see here, either P38 MET kinase inhibitor or the STC1 using the morpholino to knock down STC1 in the fish, or using mitochondria or alter the mitochondria function using the rapamycins, and as well as the lysosome by the activations using overexpressions of a TFEB as a transcription factor of a lysosome. Each one of them can alter the course of the survival of the aerial light chain injected fish. So if we are fish, I think we find a cure, but we are much more complicated as a human being. But this actually triggers something. You can thinking, what we doing this, actually, we actually provide a treatment pretty early on. Then you can say, one thing, this may not be in the clinical setting because usually you don't get detected until much later on of the disease progression. But if we spin the angle, think about that. Maybe if we can identify this disease early on in patient and apply the treatment early on, we may have a much greater chance to really not only to cure the disease, but eventually we maybe can be able to prevent the disease as well. So this is actually a data shared with me by my colleague Giampaolo Manlini and Pavia, Italy. And showing here, this is in the mortality curve of the aerial patient. This is very striking. Greater than 25% of the patient actually succumbs within the first 3 months of the diagnosis of the disease. So this is also consistent. Our thinking is, if we can have a way to have for early diagnosis and apply treatment early on, we may be able to alter this progression of the disease much better. So unfortunately, this is actually a disease still less unknown to other maybe medical center. And unfortunately, working in the Brigham and also in the past in the Boston University, they are the really national leading amyloid center. And we able to have a physician and trained fellows able to identify this disease early on. But mostly in the other university or other medical center, people still don't know how to identify this disease early. So this is also one of our goals, try to provide some sort of a maybe detection method to allow the physician can identify the disease early, and only you can identify disease early will allow them to provide the treatment early on. So with this, the current gold standard, but it's suboptimal for how you diagnose the disease is after all the clinical indication, if a suspicion is amyloidosis, you have to actually go into a myocardial biopsy. So as you know, although this is commonly done in the many medical centers, this is not without risk. So, and the other thing is actually could the potentially problem is when you go into the endocardial biopsy, you may be biopsy the sample actually show you amyloid deposition, and you may be actually miss it totally. So we don't know about that. So that's actually also very suspicious on this kind of diagnosis. And recently, using echocardiography, also developed the weights can actually, by the wall thickness and as well as the contrast, to kind of a suspicion of this potentially cardiomyopathy developments. And the most recently, we can using magnetic resonance imaging, particularly using T1 relaxation, can measure the extracellular volume. But however, this only can indicate there's potentially amyloid fiber deposition, cannot distinguish between whether that's on AL or ATTR or other type of amyloidosis, and different type of precursor protein, actually their prognosis and the treatment is very different. So this is also suboptimal. So recently, my colleague and I at Brigham's, we are actually try to investigate using the for beta pill PET imaging potentially can provide early diagnosis. And this is a couple paper we're publishing clinically by our group as well as by other group and showing this. This actually, the signal of for beta pill signal actually much higher in the AL patient compared to ATTR. And most strikingly, this only detect in the patient has active disease. When the patient undergo treatment, has a remission, you lost its signal. So this is something we are currently undergoing to test whether this PET imaging can be used for the early diagnosis. And if so, I think this completely will change in how we diagnose the patient and provide treatment. So we are very excited about that. So with this, I'm going to summarize in this. As you can see here, we actually bring out this proteotoxicity actually is sufficient to drive the mortality. And that alone already changing how the clinical practice and treatment for this disease. And this really, for basic scientists, is very gratifying to seeing our research actually can be translated in the clinical using. And as a researcher, we identify signal in cascade, and I think many speakers after me were talking about this type of study. We also always hoping our target can be identified experimentally, can be used to target for the treatment for the patient. And the last one is the most exciting one. So we are really working on identifying non-invasive imaging modality for the early diagnosis. So with this, I'm going to stop here. And really thanks to my team in Boston, and as well as a lot of collaborators. This really take a village to make this work. And without their hard work, I would not have the opportunity to present our work here. So with this, and thank you for your attention.